On behalf of Medicine 2, Dr. Pranuth will be presenting on topic titled Crystals to Clear.
Morning, everybody. Presenting on behalf of Medicine 2, Crystals to Clear. Presenting 44-year-old Mr. M from Jharkhand. He has come with complaints of multiple body swellings which ulcerated in the past 3 months. And he had a fall and a right elbow fracture 1 month back. Following, there was swelling and pain over left knee joint for 8 days, redness and pain over the left lower limb over 8 days, fever for the past 8 days, and multiple joint swelling with pain for the past 1 week. The history of presenting complaints, he developed these swellings and ulcers initially on the right thumb and then right foot, which gradually increased in size, but they were not associated with pain. But there was whitish pale yellowish discharge from the wound, but no redness or bloody discharge. There was no pain at that time. He developed similar swellings over left foot and thumb also. This is for 3 months. And then 1 month back, he had a fall, following which he sustained a minor fracture in the right elbow region, which was conservatively managed. From that time onwards, he started developing worsening swellings along with ulcers in the dorsum of foot, close to MTPs initially, and then it progressed to multiple swellings. He had history of swelling and pain over the left knee for the past 8 days. Acute in onset progressively worsened and developed redness and pain over left lower limb. It spread from heel and to the thigh onwards for the past 8 days. Associated with swelling from feet to the knee to the thigh. The pain was worse with activity and relieved with rest and medication only. Meanwhile, he also developed high-grade fever with occasional chills in the past 8 days. Along with this, he also developed swelling and pain in multiple joints, including right knee, ankle, both wrist, elbow, associated with swelling in all of these joints for the past 1 week. His movements have been limited and he's been in bed for the past 1 week because of the swelling, the pain, and inability to move because of pain. There is history of excessive consumption of alcohol and mutton in the past 3 months. Other relevant history-wise, there was no history of early morning stiffness, photosensitivity, rash, altered bowel habits, cough, red eye, oral ulcers. No loss of weight, but he has had a loss of appetite in the past 3 months. No prolonged fevers, night sweats or bone pains. No other systemic features like low stool, burning, micturition, abdomen pain, vomiting, cough, headache, altered sensorium. No history of breathing difficulty, cough, chest pain, or palpitations. In past history-wise, he's been diagnosed with diabetes and hypertension 1 year and 6 months and was on oral drugs. And he also has a history of known hyperuricemia with recurrent episodes of multiple joint pain involving first MTP characteristically. And the pain used to last for 5 to 7 days. This was all going on for the past 3 years. There is history of hyperuricemia in brother, and he is a known chronic alcohol consumer. More than 10 years, but in the past 6 months, he's been consuming much more than the usual, almost 5 days a week. There was no loss of weight, but loss of appetite was present. Coming to the examination, the vitals, he was febrile with 102 degrees Fahrenheit. BP was on the mild lower side, 100/60, and he was tachycardic, 116, with an elevated respiratory rate as well. There was pallor, and there was edema of bilateral lower limbs. Coming to the specific findings, the right upper limb, the right thumb was swollen at MCP, phalangeal joint, and there was white chalky deposits and painful restricted movements at right elbow as well. And the left upper limb, there was swollen MCP IP with white chalky deposits, but the left thumb was painless. And in the upper limbs, both wrist, elbow was swollen and tender. Coming to the lower limbs, bilateral lower limbs were edematous, left more than right and tender. There was bilateral knees swelling with tenderness with erythema. In specific, in the left lower limb, there was erythema and edema till upper thigh and increased warmth and tenderness. There was swelling of second toe and whitish flaky chalky discharge and crusting was there. Severe painful restriction of movement of knee joint. He was able to flex only 10 degrees and left forefoot swelling also was there with ulceration. Right lower limb also had edema till knee, but was less than left lower limb. Ulceration was there on the dorsolateral aspect right foot. Chalky deposits were seen. In the spine, there was no spine tenderness. Movements at the spine were not restricted. We were not able to perform Chopos or favors because of severe pain. The other systemic examination was severe first and second heart sounds were heard normally. There was tachycardia, but there was no murmurs which could be heard clinically, no added sounds. Central nervous system, high mental and cranial nerves are normal. No observable focal neurological deficits. Complete examination not possible because of pain. Abdominal examination was normal and the respiratory was also normal. Clinically, he has presented with a complex of polyarthritis, appendicular predominant, and also was symmetrical. And there was chalky deposits from the swellings. There was this history along with acute worsening following trauma in an individual with a comorbid condition, hypertensive diabetes, along with chronic alcohol intake. Musculoskeletal system predominantly involved, appendicular, with ulcerated skin and soft tissue involvement as well. Severe inflammatory conditions infective were considered. The etiologies to given the
For
slide.
the want of time, Pranuth, please proceed. Audience are free to give their differentials. Just shout it out. John? Raghu? Sorry? HPO. The other? Any other differentials? So virtually only one differential for it. If you tell differential diagnosis, I'm going to. Okay, please go ahead with your.
The first one to consider polyarticular gouty arthritis flare, and the other differentials we considered was septic arthritis as well because of toxic clinical picture along with cellulitis features in the left lower limb. Other differential to consider was CPPD, calcium pyrophosphate disease, and the reactive psoriatic were less likely. And pertaining to the left lower limb, only left lower limb cellulitis, septic arthritis was considered, and also because there was swelling and pain, DVT was also considered. Coming to the initial investigation.
Correct diagnosis, chronic facial block. Okay, it's not. See, we had recurrent episodes of classical gouty arthritis, and diagnosis not hyperuricemia. Past history of recurrent episodes of acute gouty arthritis. Then he developed top 5 discharge of the septic arthritis. Why should we consider septic arthritis? Septic arthritis comes polyarthritis. Usually mono or oligoarticular. Yeah,
so for that, the approach should be like monoarticular, polyarticular disease, and then polyarticular, like that. You can't do it. You have appropriate differentials. Because you have now it's a mashed up differential of many things to it. For poly, mono,
because you did not define the syndrome correctly. Okay. And what is anti-hypertensive medication? Was there a recent change?
There was no recent change, and there was no diuretic. Initial investigation showed a normocytic anemia. The total counts were elevated with neutrophil predominance, 17,000 with 90%. The liver function, renal function are normal. Uric acid level at the liver function test showed a mild elevated protein as well. Elevated. Albumin was low. Yes. Protein was elevated with low albumin as well as elevated alkaline phosphatase. And RFT electrolytes were normal. Uric acid was 5. The calcium corrected with albumin was normal. Phosphorus was mildly low. Magnesium was lower normal level. The inflammatory marker CRP was elevated to 106, and his HbA1c diabetes status was 6.9%. The next investigation we went ahead was the left knee synovial fluid analysis, which showed 16,000 total counts with 98% polymorphs, and monosodium urate crystals were seen in the left knee synovial fluid. Rheumatic factor and CCP tests were negative. These were the X-rays taken initially, which showed there is soft tissue thickening at the MTP as well as some erosions noted in the MTP joint as well as mild joint space narrowing. This is the left foot in the second toe where there was ulcerated lesion with chalky deposits seen. And as well as the first toe, we see there are erosive changes as well as mild calcification as well. This was the right hand where we had seen tophaceous swelling in the right thumb as well as wild chalky deposits. There is soft tissue swelling in the right thumb which can be noted also. We did not take. Coming to the discussion part of it, I want to discuss on polyarticular gout presentations. Usually, gout is present as a monoarthritis and classically involving the MTP joint, but there are, in the literature, about 20 to 30% there can be polyarticular gout presentation. And this article, 1830 patients were with the gouty arthritis, gout and arthropathy hyperthermia were checked, out of which the retrospective study. And the patients which presented with 2 or more joints with acute inflammation were identified, 102%. There was 5% of the total. And out of these, 34% had definitive diagnosis, that is established diagnosis with a synovial fluid showing urate crystals, whereas 68% they did not have a urate crystal diagnosis, but the clinical picture fitted to the gouty arthritis. Few things to note here is that the mean age in both this population was around in the 50s and 60s. And the definitive diagnosis people, 35% of the people presented as a first manifestation of acute polyarthritis, whereas the others, they were previously diagnosed as and they had a delayed onset. The mean age was the period was around 11 years, and 32% of the people in the definite group had a precipitating events, whereas in the probable group there was no much change in the first manifestation, that was 41%, whereas the delayed onset average time was 6 years and the precipitating events were 29%. Few things, other things to note was that number of joints involved was around 2 to 4 joints were involved in most of the population, and the lower limbs were involved more than the upper limbs, the knee, ankle, and the foot. And the other thing which we have noticed, the uric acid levels were normal in our patient, and in this study as well, they have noted that when compared to the uric acid levels before this presentation and during the acute flare presentation, most of the patients had a drop in the uric acid levels. 13 definite cases and 15 probable cases, they were less than 7.0. And this is a comparison showing before the event, during the event, and after the event. So your normal uric acid level does not mean that it is not a gout. And this is another study. Here they had studied polyarticular gout, 41 male patients over 3 years. The mean age was 59 years. Here we are looking at the comorbid conditions which the patients had. Hypertension, obesity, and chronic alcoholism, which are more commonly seen in our population. There were large proportion of the patients were having these comorbidities, and there was significant renal disease involvement also. And the onset of polyarthritis, simultaneous onset means that both joints have pain and swelling at the same time, whereas additive means one joint develops and then the next joint develops a later time. When looked into this picture, the simultaneous onset was seen in 56% of the joint, whereas the other additive onset and first attack polyarticular was seen 44 and 12. Fever was fever, leukocytosis, warm tenderness were predominant symptoms, and fever was present in 44% of the patients. The antecedent events which are triggered for this flare when they looked into severe medical illnesses, including pneumonia, peritonitis, UTI, GI hemorrhage, and alcohol withdrawal, severe dehydration, trauma, medication change, rapid weight loss, post-operative stage were seen in this study. In our patient, he had a trauma. He had severe alcohol intake. He had severe high purine diet intake, and with uncontrolled diabetes. Those could be the triggers for in our patient. And the involved joints in this study also has shown that lower limb joints were predominantly involved compared to the upper limb. Both were involved, but the lower limb more than the upper limb. Here also we see that uric acid levels in 46% of the patients were normal, and when we looked into what the physicians thought when these patients came into the clinic was that in 19 cases, that is almost 50% of the patients, They were diagnosed initially with septic arthritis, rheumatoid arthritis, degenerative joint disease, trauma, acute hemiparesis. When the patient severe pain and was not able to move, they thought acute hemiparesis as well. So when there is similar conditions, gouty arthritis should also be thought of, and the full clinical picture has to be put into perspective. There are few case reports.
Can I request you to wind up in a minute's time?
Yes. There are a few case reports which can masquerade the gouty arthritis. One was severe sepsis, they thought septic arthritis, and then there was rheumatoid arthritis-like picture with the cervical spine involvement because of toe pain. And there was a patient who was presented only with the delirium finding and then was found to have hyperuricemia and gout features later. And there were similar case reports only, which are also to be considered. In our patient, the MRI had shown features or suggestive of inflammatory arthritis, and secondary infection was also to be considered. So we have consulted orthopedics, and then they went ahead with arthrotomy and debridement, which showed thick viscous fluid discharge from both the knees, and which was sent for analysis, which again showed negative birefringent uric acid crystals. Counts were not very elevated. The cultures were negative. Sir,
you demonstrated clinical presentation was consistent with the diagnosis. You demonstrated monosodium urate crystals and
yes, sir. The history examination is the contiguous spread and with severe inflammatory features. Not sure about.
You're mixing up diagnosis. This gout, it is not septic arthritis. That is why you should follow the algorithm.
Not acute arthritis, it is chronic facious gout. Okay, yeah, by the recurrent episodes of acute gouty arthritis in the past. In natural history, usually you have episodes of acute gouty arthritis, you have long integrated period, then it becomes more arthritis. Then you have multiple joints in
the he persisted to have fever and then he developed ARDS, and that is thought. So, no, it was 16,000 counts.
So, Pranuth, in other words, what we're trying to ask is, what was the indication of an aspiration for this patient? You said that you aspirated, no?
Yes.
Why did you aspirate? In order to prove the diagnosis?
Yes.
No, that is not an indication for joint aspiration in gout. What is indication for joint aspiration in gout? Gout is a clinical diagnosis. You don't need to prove that there is needle shaped by negatively birefringent crystals in order to diagnose gout. It's usually otherwise evident from presence of tophi, past history of gout, very classical acute first MTP joint pain. Very rarely do you need a crystal demonstration to diagnose gout. What is the indication to aspirate a joint? To rule out secondary infection, that is indication. And you have done that, and that did not show features of an infection. So that is why you're wondering why you went ahead and did an arthrotomy. MRI is not a tool to diagnose septic arthritis. It might aid in the diagnosis.
Give IV antibiotics including for 6 weeks.
He was started on mirafen vancomycin, sir, and he persisted to have fever, and then he developed ARDS, and during the surgery had intubation and ICU stays, for which he was antibiotic was applied.
ARDS developed before the surgery?
Just before going to theatre, he had developed, and they electively intubated, and after which he was shifted to ICU.
Please go ahead. Okay, thank you very much, Pranuth. We can read that. Any further questions or comments?
In the history, it would be good to give the quantity of mutton and alcohol rather than using the assessment or judgment of excessive. Often, I will say that this person has excessive alcohol intake if they're drinking more than I am, first, and often the individual becomes the reference point. So if we can know the amount, the quantity, rather than saying it's excessive or it's deficient in the history, that would be helpful.
He had enough reasons to develop altered mental states. He was a heavy and actual technologies that their underlying cirrhosis as indicated by the prostate and severe hypertension and easy reversal high alcohol. So what is the indication for all these antibiotic after the cultures when they get the arthropods show chunky white material again monitoring?
He persisted to have high grade fever, sir, as well as his sensorium was not was worsening, and he developed this ARDS with needing intubation, and after which and the clinical septic arthritis we are thought because of this left lower limb was predominant.
First of all, the diagnosis of septic arthritis, he has poly background of all past history of recurrent episodes of arthritis, then he does a top five. So you delineate the syndrome and the post, it's much easier, then you think of each other. Fever and the swollen joint is not.
Did the patient do well after that?
Patient recovered.
I think there are a lot of disagreements, but at the end of it, we'll be happy about the fact that the patient did well. Thank you very much, Pranuth. For the third presentation today, we have Dr. Prem Raghul presenting on behalf of Medicine 3, presentation titled The Great Gatsby. I would request the further presenters not to use Slido due to want of time.